it later. I welcome Dr. Prakash, Senior VR Surgeon from Comtrust Calicut. He has immense experience in managing endophthalmitis, and he will be giving a few pearls in the management of endophthalmitis. Over to you, Dr. Prakash.
So good morning all. Thank you, Mahesh. So these are the 3 pearls which you have to remember when you face a case of endophthalmitis, which all of us as surgeons, whether we like it or not, will have to face. The first most important thing is have an early suspicion and diagnose it clinically. We don't have any supportive means to diagnose a case of endophthalmitis. You have to do it clinically and never go into a denial mode. Always think that it can happen to you and diagnose it early. Second is, whenever you have an endophthalmitis, do your maximum to identify the causative organism. And also the third thing is early and aggressive treatment. Endophthalmitis, everything is not lost. Still you can retain or regain many useful vision for these patients. So the first point, first pearl, diagnosis is clinical judgment. Because you have to decide, as Dr. Thomas was telling, we cannot postpone it to an X-ray. You have to decide when the patient is right in front of you, you have to decide whether it is endophthalmitis or not. So those are the clues from symptoms, signs, as well as a history of the patient. So the most common symptom is blur vision, but the most specific symptom is pain. So if pain is present, it is always in favor of endophthalmitis. But remember, 25% of the patients may not have pain and 15% may not have hypopain. So first postoperative day, you have a case with, it's very unlikely to be endophthalmitis, but if you see hypopain, then you have to think of it as endophthalmitis. After the first postoperative day, you have seen the patient on the first day, you have seen the amount of inflammation, then after that it worsens, patient still using drops, topical steroid drops, and it is worsening, then you have to think this could be endophthalmitis. And there are other clues, like you have to go through the history of the patient very carefully, pre-patient status. You look at the previous records, what was the status of the eyelids, was there any chalazion or anything which was done before, the surgery details, was it a prolonged surgery, was there a complication during surgery, all these things you have to go through, as well as clinical clues will be there, like if you see in the antechamber large white cells, and absence of keratic presence. Whenever KP is present, it could be a pre-existing uveitis that could be worsened. Presence of corneal infiltrates, vitreous exudates, as well as if you have fundus view and you see retinal exudates, hemorrhages or vasculitis, then it's almost always endophthalmitis. So with these clinical clues, you have to make a decision. And the biggest mistake I have seen is using B-scan, looking at the vitreous echoes and telling there is no endophthalmitis or there is worsening of endophthalmitis. Both are wrong, because vitreous echoes may be absent because for 2 reasons. One, it could be very early endophthalmitis where vitreous is only just getting involved. It may not be enough to cause vitreous echoes. First thing. Second thing is very fulminant organisms which like pseudomonas produce liquefactive necrosis of vitreous. Vitreous becomes liquefied. So you don't see much vitreous echoes. If you look at the top picture there, you see that there is significant thickening of RC complex. There is suprachoroidal fluid here, and there is that is almost like a panophthalmitis, yet you don't see much vitreous echoes. And see, after treatment the vitreous echoes has increased. So this does not mean that endophthalmitis is worsening. It happens when the endophthalmitis is responding also, because vitreous becomes more organized. The organized vitreous gives more echo. So that doesn't mean it is becoming bad. So this is one of the most important thing which you have to remember. But B-scan is essential, mainly because there could be a retinal detachment, which is a drastic complication of endophthalmitis, which you will have to diagnose. There could be masquerades like a retained lens matter, which also can be picked up only on B-scan. Second thing is, you have to go to any length to identify the organism, because for that particular patient it is important, so that you can give the optimal medical care for that patient. Also, you can make decision on early vitrectomy, because you identify a gram-negative organism, you would always go for an early vitrectomy. Also, you can prognosticate the disease. Medico-legal, it becomes, remember, it's not that you caused endophthalmitis, it's not the medico-legal issue. The medico-legal issue is you have not taken a standard of care in identifying and managing it. So that is the biggest problem. So to that extent, this will help you, and also prevent further outbreak. You know what is the organism, then you can prevent it if it is from your side, from your operation theatre. So the best and safest sampling method is taking an acid tap, which could be done by any anterior segment surgeon. And you always have a direct plating, because the yield, even in the best of the eye institutes, is less than 50% microbiological yield. So direct plating improves microbiological yield. So keep a culture plate in your OT. Even if you have a small hospital, you can contact the nearest lab, who will be happy to keep a plate there, which they will take if you are not using it. take back. And also keep a specimen back in your fridge for sending for a PCR if you don't get in routine microbiology. So it's very important to identify the organism. And third and most important is early aggressive treatment. So whenever you are diagnosed clinically there is an endophthalmitis, give an intravitreal antibiotic. That's a mainstay of treatment for endophthalmitis, because vitreous acts as a reservoir where your intravitreal antibiotic will lie, and it will, over the next 48 to 72 hours, it will release enough concentration of antibiotic to prevent further growth of the organism. And also keep the patient admitted in your hospital, monitor the patient every 4 hourly, and give systemic antibiotics with good ocular penetration. And the then last but not least step is decide whether this patient requires an early vitrectomy or not, and if it requires, send him early to a VR surgeon for surgery. So here your decision making is dependent on what is the onset of the endophthalmitis. It's a fulminant, that is less than 4 days is called as fulminant endophthalmitis. Then that means the organism is either very aggressive, or you have inoculated a large amount of organism along with the endotoxin, probably a contaminated fluid, into the eye. So these cases, not only treating the organism is not enough, you have to remove the endotoxins as much as possible, which is only possible by doing a vitrectomy. The other situation is the patient is not responding to initial intravitreal antibiotic. You assess for next 48 hours. If it is not responding, then you have to go for vitrectomy. And also if you have a complication like retinal detachment, you will have to refer for vitrectomy. So these are the 3 pearls: diagnose early, identify the cause, or make every attempt to identify the cause, and treat the patient aggressively. Thank you.
Thank you, Dr. Prakash. In summary, it is the value of time. You should not waste time, and systematic management as per the protocol. So